So thank you so much for that kind introduction. My name is Baugh, but today I'd like to speak with you about someone a little bit more important than I. W. Montague Cobb was the chairman of anatomy at Howard University and the only black anthropologist in the United States until the time of the Korean War. Almost 90 years before us, he realized that describing performance solely in terms of biology could be reductive, and used his acumen as a clinical researcher to help demonstrate the point. This morning, I've been tasked with telling you the story of his work and how it relates to our broader struggle to understand race-based medicine using pulmonary medicine's experience with lung function testing as one specific example. So let's go on ahead and jump right in. His question was not about lung function, but he was trying to understand athletic performance. Specifically, why did black athletes do so well? And so here you see a picture of him as a young man, literally using calipers to measure Olympian Jesse Owens' calf muscles. But what he said is, as he started to talk to star athletes and famous coaches and award-winning sports commentators and really nail them down on, well, what is it that makes the best and most excellent runners? They couldn't really tell him with much specificity. He said he was almost at once beset with vagaries. And in my own attempt to understand lung function and its relation to race, I could only relate. You see, we have a very interesting and concerning trend going on, where on the one hand, our lung function tests are supposed to be the primary way that we understand this organ. But on the other, when we go through disease after disease, it's losing relevance. And so how does that make sense? What am I talking about? Well, first of all, if you look at the lung transplant guidelines starting in 2020, they completely removed measures of lung function from the priority of waitlisting who gets to get a new organ transplanted at all. In COPD, the divergence between your symptoms and your lung function is so wide that it has like a whole chapter or section in our guidelines explaining this. And they had to develop a separate system to determine how we prescribe medications for COPD because of it. And in asthma, lung function has been not very relevant for a long time. And if you look, the trend is that it's just decreasing even further and further in relevance. And so when we see this pattern, we have to ask, well, is there something systematically wrong in the way that we're measuring or reporting and understanding the interpretation of this organ's function if it's losing all this relevance in these different categories? So let's try to understand, how do we interpret lung function? The key point I want to make to you is that unlike some other organs, there's no gold standard for understanding the lungs. We can't say what your lung function should be with perfect accuracy. So instead, we compare to a similar group of people. And that similarity is based on 4 different dimensions. We talk about age, height, your sex at birth, and your race. And immediately, the odd one out there is that race is the only one that doesn't have a clear and fixed definition, and it's the only one that is not externally verifiable or measurable. And so how does that get us into trouble, or could that be a cause of our problem? Well, let's take a step back and look at this directed acyclic graph. Now, the function of these is that it helps you when you're doing either a study or a clinical algorithm to understand what is the meaning of this variable, what purpose am I putting it into the equation or the research question for. And if we say, well, I really want to understand lung disease and I want to clear out other factors that could be affecting it or could be extraneous to the outcome, like, income or poverty or whatever, right? And really just look at the biology. You could see how a lot of people would want to think about the top half of this diagram. They could ask, who are your parents? Who are your grandparents? Maybe did you inherit a certain gene from them or a single nucleotide polymorphism? Is there a special genetic linkage that runs in your family? And maybe this creates a certain different protein expression that gives you a different disease phenotype that we can see when you show up in our clinic or in our hospitals. That makes sense. But because race doesn't have a fixed definition, as we were saying, we also have to acknowledge this bottom causal pathway. And so in that one, people have to think about questions like, who is my family? What has their experience in this country been? How does my personal experience and maybe the ways I've been treated or mistreated in society influence both my place in it and my outlook on the world? And so if they're using or thinking about that causal pathway, you may not be, reducing confusion or eliminating extraneous factors, but you may, in fact, be introducing it and causing confounding in the way that you're doing your research or in the way that you're delivering care. And the only way we can choose between them is knowing the importance of these two pathways relative to one another. After all, if everything can be explained by the top pathway with these benign and sort of innate explanations, then it doesn't really matter that the bottom one theoretically exists. Whereas if the bottom pathway is really important and really explanatory, well, then we got a big problem because we're introducing a lot of confusion and confounding into how we're delivering care. So let's explore which one of these is important, what we thought about in the past, and what we can learn now. So the most common explanation that you're likely to hear, and the one I was given in medical school, was that the average differences in lung function that exist across racial ethnic groups is all about body proportions or anthropometrics. So because people of African descent tend to have shorter trunks and longer limbs, as the argument goes, of course it's the case that if you put two people of the same standing height side by side and measure their lung function, the person that is African descended or black is going to be more likely to have a smaller chest and therefore a smaller lungs to fit in that chest and therefore a lower lung function. It's only logical, and it's great logic. But what does the data say about whether that theory holds up? Well, Dr. Herrick Kahn tried to look at this, and he used the NHANES data set, and he said, I'm going to use sitting height to get around this difference in leg length and just measure, from the waist up and get a better idea of the chest. And it was going pretty good. He found it explained about a third of the average differences between racial groups and their lung function. And that was just with sitting height. He wasn't even measuring the chest that exactly. So you have to imagine if we were just a little more precise in capturing what are the dimensions of our chest, maybe you could explain more and more of that difference until you got all the way to 100%. The only problem being Dr. David Jacobs already tried this in 1992. He used the cardia cohort. This is a large, very well characterized cohort. It has the highest quality of spirometry available. And he used not just one dimension to understand these body proportion differences, but he is looking at 5 different ways to measure these proportional differences in people's bodies. But a couple of things happen. Number one, when you look at table 5 of his research paper, what he shows you is that this explains not 35% of the average differences, but drops to only 25%. And so he had to conclude whatever the reason for this difference that exists by race and lung function is, it's definitely not the body proportion or the anthropometry alone. And I'll just observe, I think this is the only time in my education from kindergarten till now that someone told me the primary explanation or the favorite thing that people like to say is something that covers barely more than a third of the data, like over half is just we don't know. And yet this is what people were content to give me an answer for. I think, as Dr. Cobb said, it's a lot of vagary. Now, thankfully, there are other more sophisticated researchers came along and they had other ideas. These are people like Esteban Burchard, K.M. Menezes, Dr. Kumar. And they noticed this association between genetic ancestry and lung function. And this is pretty robust. They did this in different age groups. They've studied it in different countries. They've even been an exception to the over 90% of studies done before 2010 or up to 2010 that didn't even include any measures of socioeconomics at all, which is to say they did try to take some of these factors into account in at least limited fashion. And this is a very robust finding. If you have greater African ancestry, you have lower lung function on average. This is the association we tend to see. And I have never seen a single modern study that ever contradicts this. So what's the problem? Two caveats. First of all, even if we treat the ancestral contribution as completely separate from the body proportion contribution, which is a little odd since we would normally say that the way our bodies grow and develop is informed by our genetics, but never mind, let's give them the benefit of the doubt. And even if we use the upper limit estimates of what impact this genetic association to ancestry can have, you still have this very big fraction that is completely unexplained in the difference between different racial groups' average lung function. And so I'm asking you, what is this? It's not your body proportion. It's not your genetics. What other benign or inborn kind of explanation can you give me for what it is? Again, I see vagary. But the problems go a little bit deeper even than that. You know, Dr. Menezes, who was working in Brazil, correctly observed that it is very, very difficult to disentangle, although the data reports it as, hey, this is associated with the genetics. It's very difficult to say, is the true cause of this because of those genes, or is it due to a social difference? Because the fact is, people who are more genetically African often tend to be more phenotypically African. And so because of that difference in appearance, they're flagging themselves for potentially a different social experience of maybe catching more discrimination than others. And so now you can't say, is it the social treatment that they're having that's driving this association, or is it truly these genetic differences that we are detecting? But thankfully, if our modern studies cannot resolve this, perhaps a point of historical comparison can. By comparison through modern studies, perhaps a point of historical comparison would be helpful. This is a letter written by State Senator Edwin Belcher to abolitionist William Lloyd Garrison, given to me by a friend of mine, Dr. Belcher, Harlan Belcher. And so observe two things that he says. This is a mixed race individual. At one point, they could not even establish he was even 1/8 African American. And yet in his letter, he starts, first of all, he was born the slave of his father. And then later in the letter, it emerges that he's asking for work, and he's talking about his struggles and his treatment. And he talks about the way that he's commonly addressed when he's walking around town and in society. And you know what word is blurred out there. And so this brings us to a concept that is called the one-drop rule in American history and society. And this is the idea that if you had any part African ancestry, you were treated as entirely black. And this provides us with an opportunity because after the Civil War, in which Edwin Belcher served as a Union officer passing as white, there was a study done of all the Union troops kind of surveying different measures of health by astronomer Benjamin Gold. And one of the data points he collected was on their lung function, dividing them into black, white, and mixed race veterans. So now we have the opportunity to do a little test here. If the genetics are really determinative, then what we should see is that the mixed race veterans have to have a lung function that is in between the black veterans and the white veterans. Every study has shown this, never contradicted in the modern day, right? But if the social experience is in fact what's influencing these results, well, then a picture's worth 1,000 words. The mixed race veterans have lung function that is exactly on top of the black veterans, because the reality of the post-Civil War era is that mixed race people were treated exactly as black people socially, regardless of what their genetics were. And so this opens the door to questioning an assumption we've had a long time in pulmonary about what is the influence of social and environmental factors. You see, Dr. Cobb, after he'd done all his measurements of muscle lengths and bones and anthropometry, and found that there were no differences in body proportion that could explain the excellent performance of athletes, he then started to ask questions about what are the quality of the institutions, the training facilities, the coaches, the support they have for the student athletes. And he concluded in his study that the much more important factor was experience and better nurture, in his parlance, the impact of social and environmental influence. Now, we, as I said, have downplayed this for a long time in pulmonary medicine, but I think there's some significant evidence that should make us question that assumption. Let me introduce you to Massey and Massey. This is a husband and wife couple that studied 118 Japanese Americans and their lung function. Now, every one of these participants had 4 Japanese grandparents fully, so there were no genetic differences in this group or study. But what they did have is a difference in life experience. So among those who spent their childhood and early life in the Japanese Isles, their lung function followed exactly the prediction equations that we have for Japanese people. It made sense. But among those who had spent their formative years and lung development years in the United States, which at the time relevant for inclusion in this study would have had a GDP that's at least 3 times larger, well, all of a sudden their lung function was much larger too, and it fit much more on the curve that we had developed for white American people. And so how is this possible if it's only genetics and there's no social influence, that in a single generation, a simple change in location could cause a change in your lung function? Let's flip that around and say not a single generation in multiple places, but let's stay in one place across multiple generations. You might know that the country of Taiwan was formed on the island of Formosa by Chinese expatriates that had lost in that country's civil war against Mao Zedong. And they had a pretty tough go of it initially. The island was pretty resource poor. They lost about half their industrial capacity in the 1940s during World War II. And then they had just really staggering inflation through the 1950s, regularly hitting at 20% and above on a year-over-year basis. And you know how much we've struggled with just a few months of 9% inflation, now at about 3%, I think. And so these people were part of the first study of lung function of Taiwanese people, trying to establish a reference equation. Now let's fast forward to the 1990s. Taiwan is one of the 5 tigers of Asia, one of the largest and fastest growing economies. Everybody wants to invest there. And in that bumper crop of affluence grew the children that were a part of this second study that was done by Dr. Wang. This is this VGH Healthcare. And look, all of a sudden, the lung function of Taiwanese people living in Taiwan has suddenly and magically increased, despite not being any increase in, or any change in the population's demographics or genetic composition, right? And so Dr. Wang, although he's never been a part of this race and pulmonary function debate, and he's never met, I know someday he's going to track me down for always bringing him up. But, he was forced to say in his conclusion of just trying to write a normal paper updating reference equations that the enormous economic growth and changing social conditions in his country mandated periodic updates in the pulmonary function reference equations. And so now we say, well, can we do the same thing in the United States? And so I had a cohort about 2,500, so 2,000 white and 500 African-American heavy smokers. And I was trying to understand what is the influence of social conditions on their lung function. And I developed something called the Adversity Opportunity Index. We used 5 measures of historic and contemporary privilege to measure. So things like household income, educational attainment, dusty jobs as a metric of blue-collar work, access to fresh and healthy foods. And the higher on that scale, kind of the more privileged you are. And when we look in our white patients, we see that as you get a better job, live in a better home, that's associated with higher lung function. It makes sense with what we were seeing in Taiwan, with what we saw with the Japanese Americans. But among our black participants, let's think about this for a second. This is not a parallel line. So it's not that, there is some innate thing that's inborn in them and it makes equally low and equally high, right? But instead, everyone has low lung function in adversity. But in privilege, you don't see that benefit that you saw with white participants. And so how is that possible? Well, Dr. Asari at Charles Drew University talks about something he calls minorities diminished return theory. And this idea is that when people are marginalized in a society because of the extra barriers and obstacles they face, they may not realize the same rewards of their work as other people. And we can see this demonstrated really well in what I'm showing you here, which is just a meta-analysis of several decades of a very simple study design. Take an identical CV or resume. So everyone has the same prior work experience, the same letters of reference. They all went to the same excellent school, Wharton School of Business, or whatever your favorite is. And all they change, there's no explicit mention of race, but all they change is the name on top. Is it a white-sounding name, or is it a black-sounding name? Now, what they found, whether they had an exotically black-sounding name like Kamal Kambui, or whether they used something a little more pedestrian black-sounding like a Reginald Washington, if they could identify, hey, from this name, it's more likely that this person is black, they were much less likely to be called back for a second interview or for a job offer. And so even though you could say that all the people invested equally in, getting a good education and working hard at their prior jobs, the black individuals did not get the same return on their investment. It was diminished because of their race. So minorities diminish returns. And then we have to ask, we can see this socially, sure, we saw this in the job market, but does this really affect American healthcare? All right, so this is studied by Dr. Kothari. She's working in Southeast Michigan, about an hour from where I grew up, which is Ann Arbor. And she was trying to understand low birth weight pregnancies as an adverse pregnancy outcome. And so interesting thing, a sad reality of our country and a lot of the world is that poverty or low income status is associated with more adverse health outcomes. So unsurprisingly, she found that in parts of the study parts of the community that were lower income on average, you tended to have more low birth weight pregnancies, par for the course. Regrettable, but something we know we need to work on. What was surprising is that when she looked at black mothers in the high income areas, those were actually the worst outcomes you could get in terms of low birth weight pregnancies. So to be clear, this was not seen among white mothers in these affluent communities, nor was it seen among black mothers in communities that were more diverse. But there was something uniquely hostile or oppositional about the health outcome we were trying to achieve when you put being a minority person and being, one of only a few in this environment that otherwise you would have thought, hey, this is the ideal environment. So again, diminished returns on the pregnancy outcome. And so we can ask, might we be seeing this in this odd gap that's opening up on the right side of our graph of lung function? All right. So now, as Dr. Cobb moves on in his study, he brings up this next idea. He talks about a different kind of athlete or champion. And this is a jumper, a short Asian man. And he kind of comments that if all these racialized theories were correct, that this individual's success makes no sense at all because it's all the wrong proportions and it's just not right to what you would expect for how he should be so successful. And so let's try to do that as well. Let's forget about all these theories and different, whatever studies, let's try to meet where does the rubber meet the road for a clinician in the hospital. Our assertion has been for decades that including race, again, was supposed to enhance our understanding. It was supposed to reduce confounding or confusion and therefore improve our ability to understand who is sick and who has disease. Let's just look at some clinical data. Does it actually do this, or does it do the opposite? All right, so the first outcome we'll consider is vital capacity. This is named vital, like the ability to stay alive, because actually the inventor of the spirometer, John Hutchinson, he recommended this as a usage of his new device because it was so obvious. It was like the first thing we ever noticed when we start using this is that there's such a strong correlation between your lung function and how likely you are to die, mortality risk. And so how does the use of race measure up here? Well, when we use a race-based interpretation system, which was supposed to improve our understanding, we get this really odd thing where, your lung function being one thing means something if you're black and something completely different if you're white. So it's like you can't really use the numbers comparably, even though it was supposed to be making them comparable. But when I use the race-neutral system, okay, then that effect goes away. And all of a sudden, the lung function measurement that I get from the interpretation applies equally to all people, regardless of their race. Now, if you're thinking pretty quickly on your feet, you might say, all right, Dr. Baugh, you're pulling a fast one on me. The causes of mortality are different by different racial ethnic groups. And a lot of causes of mortality don't even have anything to do with lung function. So couldn't this just be a spurious association? And yeah, you're right. So let's try to tighten this up a little bit. Let's look at something really drilled down. This is 30-day post-operative complications after lobectomy or lung resection, usually for cancer, but also for other severe lung disease. And what happens here? This is a 10-year retrospective cohort from MD Anderson Hospital. So you had to be very affluent to get into this hospital, and very privileged. Most of this cohort is white, so we can't get at all the questions we're hoping for. But it does get at this questions of confusion or confounding, right? Because what we can say is that, again, if race is really improving things so much and giving us more clarity, we would expect that a model that includes race would be able to better discriminate who's going to have complications or difficulty after surgery than a model that doesn't include or acknowledge race. But when we actually look at these, numbers, when we actually look at these numbers, what we see is the area under the curve, or the discriminating power to say who has a complication or who doesn't, is almost exactly the same. So stated otherwise, the inclusion of race had absolutely no benefit, and the removal of race caused no harm. So how is this possible if the argument is that, if we ignore race, we're going to be overestimating the lung function of white patients. We're going to be causing them harm. We weren't able to see that in this study. Let's consider some other outcomes. This is symptom burden, again with my 2,500, 500 African American, 2,000 non-Hispanic white. And again, we see that if we're going for this idea that a single lung function should give you a single set of symptoms regardless of your race, the way we get there is a race-neutral setup, not a race-based one where you get these odd, it means two completely different things depending on what your race is. And what I'll point out, if you look at the slope of these lines, the slope of the white equations does not change that much in this regression, but it's the black regression that changes a lot. And so we're not decreasing the sensitivity for disease in whites, but we are substantially increasing it in our minority populations by using a race-neutral interpretation. And I wanted to do this not just graphically, but statistically. So I used something called Alpayton's 5x2 CVF test. And this is a technique that's developed from machine learning. And I'll say it's just a little bit more statistically robust. We'll stop there unless there's specific questions later on. And we looked not just in symptom burden, which is self-reported, but functional outcomes like the 6-minute walk test, and also radiographic ones like airway wall thickness. So no way someone can consciously manipulate how their airways look on a CT scan, right? And in all these, the race-neutral format had a much better correlation to what we actually saw clinically than a race-based interpretive format. And the one outcome maybe that was a little more equivocal was emphysema. We were using quantitative emphysema. So then along after me comes Gabrielle Liu, very smart person. I encourage you all to speak with her sometime. And she's using not quantitative emphysema, percent by percent, but visible emphysema, so what a physician would recognize with their naked eye and would be clinically actionable. Now, what she found is that when you are looking at normal range lung function, so here, among black people and black men in particular, you are much more likely to have visible emphysema at a quote-unquote normal lung function under a race-based system. So that means that if you're using your lung function test to gatekeep, who do I need to give a CT to? You're going to miss all those cases. But now, if we use a race-neutral interpretive format, all of a sudden these 95 confidence intervals, look right there, are overlapping so that you're no longer missing disproportionately more black people with disease. We haven't, again, diminished the sensitivity for finding disease in our white patients, but we are increasing the sensitivity to capture these important diagnoses in our black ones. So let's go ahead and try to wrap up here. We at one point believed that average differences in lung function across racial ethnic groups were entirely innate and benign. But on examining more closely, we found that a lot of those arguments were lacking in rigor and evidence. We asserted that the role of social and environmental influence was pretty minimal on lung growth, and yet we've seen some significant data that contradicts that view. And finally, it was our belief that these differences by race and ethnicity were not clinically important and shouldn't inform care, and so we needed to develop an interpretive system that taught us to ignore them. And yet we're amassing more and more evidence, as I've shown, that when we actually examine clinical outcomes, it's at best having no impact and may, in fact, be doing the opposite. And so having answered these three questions, we need to close by just discussing three individuals. The first is Harvard anthropologist Albert Damon. Now, he's very celebrated and was, in fact, on the executive committee of his discipline's most prestigious professional society. So you have to ask why his paper, which was so influential in creating for us as a community this idea of racialized lung function interpretation, why does he spend his final paragraphs of that paper, like literally the last thing he leaves you with before he goes to his abstract, is talking about black athletes and Olympians in exactly the ways that Dr. Cobb had already debunked decades ago? And I want to propose to you is because he's human. We need to abandon the idea that physicians and scientists are somehow above the world and instead acknowledge that they're subject to the same passions and prejudices as the rest of us. Number two, let's return to Dr. Cobb. How did he get involved in this debate? Well, Dr. Cobb saw and acted on structures of inequity. He was the founder of the Imhotep Society, which was critical in advocating for hospitals to open their staff to non-white physicians. He advised the movement, or the March on Washington's sit-in strategy for protesting for civil rights. And he was even a president of the NAACP. Now, he, though, as a child, what started him on his career in science is that he saw a book which, in his words, displayed to him the separate dignity of the races. separate dignity. Think about that. So a racialized approach, just like we're talking about. And sometimes people ask me, well, Dr. Baugh, are you saying that we shouldn't be trying to understand better diversity and human variation in our population? And I say, no, 1,000 times no. Dr. Cobb started there. But the thing is that after he followed the evidence, when he put himself aside and tried to drill down on answering a scientific question in rigorous fashion, he found that he could no longer justify this essentializing, biologically determinist argument. And what's more, he saw the connection of this pernicious ideology to the broader structure of American inequity. One last individual, Jesse Baugh, lived around the Chesapeake and was alive at the War of 1812. So he watched family and friends seek freedom in the ranks of the British Army. But he chose to stay behind. Although he was intimately and personally aware of the failures and shortcomings and hypocrisy of this country, he stayed because he believed that it could be better and that he could have a role in making it so. My name is Aaron Dorian Baugh. My first ancestor was a slave on the shores of Anne Arundel County. And in his legacy, I ask you this morning that we not content ourselves simply with describing the deficiencies of the system we have, nor that we give up in disgust and cynicism and walk away saying nothing can change, but that we have the courage to believe that you join with me in trying to build something better. Thank you so much, and I'll open for questions.
Oh my gosh. A little verklempt myself. That was extraordinary, really. We do still have about 10 minutes or so for questions. We'd love to invite some questions. I don't know. I think, Eliseo, do you want to maybe jump up with the first question, if just a reflection, if you'd like? Only if you'd like. You don't have to. I had. Okay, no worries. No worries. Thank you. Who's got a question? I can't see. Oh, please, right here. And can we grab a mic? Oh, do you want her to get up? Okay. Yeah, I guess it's wired. Sorry.
Yeah, thank you. Good morning, and good morning, everybody. Thank you, Dr. Baugh, for an outstanding keynote. My name is Dr. Ijeoma Nnodimopara, physician scientist and lead work in ending race-based medicine in Detroit, Michigan, at Wayne State University School of Medicine. That was outstanding. I particularly was drawn to your storytelling approach and just the beautiful marriage of the personal with the science and the medicine. And this is something I try to infuse in my teaching and practice as well. I'd like to ask, as you have leveled this powerful call to action for us, what are some tips that you would offer in terms of how we use the power of storytelling to indeed courageously lead the work of change as you have called us to do?
Thank you so much for that wonderful question. I think one core thing is that, physicians are excellent storytellers. So Arthur Conan Doyle, the author of the beloved Sherlock Holmes novel, was not only a novelist, but also a physician. And so, and also when we collect patient histories, right, it's all about understanding what their stories are and contextualizing. And so what I think we can do for policymakers, what we can do for communities is to bring out the commonalities in things that look different and things that look difficult to understand. But how can you find a way that this community or this audience can connect to, like, where does this touch my life at? Or where do I see something similar in my experience? And if we can bring it to people kind of on their terms, they're going to be more open to it than just a discussion about, like, oh, this is a topic for those people over there, or this is about them. It doesn't impact me. It has no meaning. But you got to bring out for them, how is it going to connect to my life and the things I care about?
Thank you so much. That was just an extraordinary opening to this meeting and such a wonderful talk. Tina Hernandez-Boussard. I'm at Stanford University and I'm a data scientist. So I always think about the data we use to answer these questions and to look at these questions. And so I'd like to hear your thoughts on, what are the pieces of data we're missing to really dig into this? Because we have a lot of work on, we're going to exchange race with zip code or maybe something else. But if we really truly can get at some of the underlying processes that we want to capture, what would those data pieces be? And how would you suggest we obtain these from different communities? Because what we're doing is not working, right? We're collecting the same data we've collected for 200 years. And so what are your thoughts on that?
Sure, excellent. And let me speak with specificity in my field. So I'll say, number one, I'll name three things. Number one is when we talk about understanding lung function differences around the world, we first need to be truly around the world. So where don't we have spirometry data from in all these debates? Any of sub-Saharan Africa, any of the Indian subcontinent, the country of France, Oman, the Philippines. So all these huge blind spots that we now then want to talk about what are different groups' lung functions, but we don't even have much data from those groups. Number two, if we want to understand the connection between social status and health outcomes, we need to understand not only the minority populations who are in adversity, but those who have achieved success and are in affluence, a big missing gap in many of our data sets. And then number three, I think we need to continue to improve our sophistication in how we measure and assess social status using just income or just zip code are very crude measures, especially in comparison to the sophistication of these multi-genomic gene chips and things like that. And so, it's no surprise to me that they can measure with so much more precision and capture so much more when they are looking at a much more granular level than the kind of crude and coarse measures we've been using. And so those are three areas I think we could improve.
Great. Thanks.
Yep. Thanks so much. What a tour de force. So my name is Bill Dayhut. I'm the Chief Scientific Officer for the American Cancer Society. And looking at prostate cancer, we know our cancer incidence rates are higher looking at black men than white men. Mm-hmm. Our mortality rates are significantly higher. Mm-hmm. And so when we break down mortality, probably a small percentage of that is cancer biology, but a much larger percentage of that is biases and social determinants of health. Mm-hmm. So how do we begin to focus on these issues in a way that's sort of race neutral when so many of the disparities are our biases and our way we are perceived as race, particularly in an area when we have not made any real progress in cancer disparities outcomes?
Yes, excellent question. And so I think this is a key distinction to make. I never advocate for race-blind approaches. Mm-hmm. But what I want people to look for is how do we achieve race consciousness? So you see, even as we gave this talk and talked about a race-neutral interpretation strategy, we spent a lot of time talking about the history of race in this country, and various individuals talked about Edwin Belcher and things. And so it actually required a deeper understanding of the Black experience, not a more crude one or less of a look. And so sometimes race consciousness means adding race to your consideration, but it's understanding that this is, what does this mean sociologically and things, and not treating it as, oh, this is inborn, this is biological and inherent, this is not something I can take action on or modify. And so I guess that's my answer. You want to be race conscious and think about how race affects people's lives in the right ways and not misapply stereotypes or misinformation on how it might affect their disease in ways that don't hold up by the data.
Thank you.
Yes.
I'm going to take a question from the virtual audience. Kevin?
Sure.
how do you reconcile the review of the literature and your take on the topic with James Diao's recent New England Journal of Medicine article related to the impact of the new GLI race-neutral equation? And a related one is the study that's being referenced here showed that similar AUC for race-based and race-specific equations for predicting 11 clinical outcomes, similar AUCs. If race-neutral equations help us identify people with subclinical disease better, shouldn't the race-neutral equations improve prediction of clinical outcomes?
Excellent question. So James does really great work in all that team, so I definitely recommend the article to you. For those that don't know, what he looked at was a couple outcomes. He used NHANES, he used the UK Biobank, and then he used the UNOS data set for lung transplant and compared a race-neutral and a race-based interpretive approach to see what would these differences be among job eligibilities for high-risk professions like firefighting, for payments for U.S. veterans, and then also for lung transplant priority, and compared them to outcomes, right? And so the things I would say about that are this. Number one, he's absolutely on the right track. We have to have these discussions about what a transition would mean. It's the most important work of the day, and so my hat's off to him. In terms of the outcome differences, the assertion that we had for why we were including race was that it was going to improve our outcomes. And so if the inclusion of race does not add value to the model, and we say this generally in model building, right? If you have a variable that adds no value to a model, why is it being included? So I think kind of the burden of proof is maybe reversed there. Now, on the other hand, for how do we understand these consequences? These consequences are somewhat arbitrary in that they are the result of a system that has been built up over decades, presuming that the race-based system was true. And so now that we have evidence that maybe it's not the best, what we need to do is go back and re-examine all these thresholds and say, is this current to the best level of evidence? And this is not something we should just be doing because of the race issue. But, for instance, the lung cancer resection guidelines, they're from 2013, I believe. And so think about how much the care of lung cancer has changed since 2013, but no one has thought to do any revision on how do we manage these surgically since that time. And so it's not that, we're behind somehow, but that this discussion we're having about race is allowing them an opportunity to hey, maybe we should be updating this guideline for current evidence anyway, and would give us better outcomes for everyone. The last thing I'll say is he uses modeled outcomes. There is more specific data available, so rather than using the general population and applying firefighting standards, you could get a study of actual firefighters and apply firefighting standards. And I think those things are going to help us get higher precision in our results as well.
I'll be these three questions and we'll wrap up. Go ahead, please.
Good morning, Dr. Baugh. Great to see you again. John Icarino, American College of Chest Physicians. You actually covered a lot of what I was going to ask about. And to kind of maybe further that discussion a little bit, I'm a pulmonologist. I'm biased. I think PFTs are used a little differently than a lot of clinical algorithms because they are used for occupation, for surgery eligibility, as well as to diagnose disease. So there's so many uses for the pulmonary function test. And I'm curious if you think that we're just over-reliant on PFTs, that we're using them for things that they shouldn't be used for, like occupation eligibility, and we should be using other measures, other metrics, or if there is sort of a perfect answer out there where we can really define a single test for all of these uses.
Great question. So I think there's kind of two alternate pathways we could go. One is to say, yes, that it's a little of a stretch to imagine that one number is going to answer all these very different questions that are really about different modalities and function of the organ. And so maybe we should just be using different metrics as has been raised. The other alternative is to say, maybe what we need to do is not just have a single interpretation strategy, but maybe the way we interpret the raw data needs to be shaped and relevant to the specific question that we're asking, right? And we do this in other parts of medicine too. When we get a white blood cell count, It's not that like one number absolutely means something, but a white blood cell count in a person with fever and productive cough and means one thing, and it means another thing for a healthy young person that's a couple hours after surgery, right? And so figuring out ways to can we interpret this data in light of specific questions better, and maybe that will give us more precision in our work.
I'm Michael McGinnis, the National Academy of Medicine. Thank you, Dr. Baugh, for a really extraordinary presentation. You packed more issues and questions around fundamental issues into an understandable short period of time than I've heard. Really extraordinary contribution. Since Helen started to ask an unfair question to Eliseo, unfair because he wasn't in the room, I'm going to channel Eliseo. I'm going to channel Eliseo.
Charlie's right behind you,
Oh, he's right here? Okay. I didn't see him sneak up behind me.
Channel him and then.
Okay, well, I'm going to channel him anyway and say, I've just been appointed by the director of NIH to lead a new initiative to try to get at the core issues that you've raised in your talk. What do you call that initiative, and what are the first two programs that you launch under it?
Okay. That's quite a challenge. I would say if I had to drill down on what are the most fundamental issues here, I don't know that I have a name. I'm not good at naming things. So I'll pass on that question. But I'll say the most important issues to me are, number one, trying to understand how, organ biology and physiology connects truly to relevant outcomes, and what are those relevant outcomes can we define. And then number two, understanding what factors are, modifiable to either enhance or have a deleterious impact on that organ function to bring it back. Those are the two.
Thank you.
Thank you. Okay.
Thank you. I'm Eliseo Perez Estable. I'm the director of the National Institute on Minority Health and Health Disparities at NIH. So I missed a lot of your talk, so I apologize. I can't react completely. But I did want to, first of all, applaud the fact that you're generating data on these algorithms and trying to sort that out rather than create dogma one way or the other. And so I think that's what we need. But I do want to emphasize that race and ethnicity are fundamental social constructs. And you may have said that at the beginning. They're self-identified. They're factors that matter in almost all health outcomes that we evaluate. Mm-hmm. Parallel to socioeconomic status. And I do think that social class, socioeconomic status, we do have precise ways of measuring the latter. That zip code or self-reported income have its issues. Mm-hmm. But when you look at the data, it's compelling. And yes, race and ethnicity do influence mortality in the United States. That's been looked at numerous times, including ourselves at NIH. And it is a dramatic difference that has persisted over time, even with all the errors of measurement that one can factor in. Mm-hmm. And last, I would say that in a clinical context, understanding who your patient is something we forget. So I would argue that the fundamental issues is how do these social and behavioral constructs interact with biology? That it's not a matter of race is biological. We dismiss that. And I don't think anyone at the NIH directors tables agrees with that. Even though there are a lot of scientists out there that do believe that or treat it like that. And we think that's fundamentally wrong. But it is a tool to understand mechanisms. And there are discoveries that have been made as a consequence of this, including, you alluded to genetic discoveries as well as probably metabolic pathways, and how perhaps things related to the epigenome react, both to social adversity as well as how one interacts through their own experience. Since race and ethnicity do bring with them lived experience, That's probably what we're representing when we ask for this crude factor we call race and ethnicity. And I believe this applies globally. It's not a U.S. thing. Being from Latin America, I very much believe that, and I think increasingly so in countries where we're seeing more diversity. So I just want to make sure that that this conversation had that statement if you hadn't already said it. Thank you.
Yeah, of course. So that is extremely important, and let me just underline that again. You might have noticed in my talk, I try to say always social condition, not simply socioeconomic status, because you see this argument from people like, for instance, Thomas Sowell that say, oh, this is all just about, black people happen to be poor and minorities happen to not have much money, and if you looked at that, that would explain everything. But no, I try to be very explicit that socioeconomic status is not all of social condition. What am I trying to say to you? Racism is real. Discrimination is a meaningful factor in people's lives and in their outcomes. And not simply discrimination and adversity, but also talking about resilience, success, and the ability to overcome those factors. And unless we are taking those things into account, unless we're capturing them somehow, you will never fully understand an individual patient's story and the care they need, nor will we understand at the population level what our communities need in order to get better. So thank you so much for that.
Good morning. First, thank you for an amazing talk. And I'm a little intimidated to ask this question, one, because it's a bit provocative, but also there are a lot of very smart people in this room. What I find myself wondering is we talk about trying to distinctly measure what might be biological drive differences in health and health outcomes versus social differences in health and health outcomes. Is there a third measure, and I think you were getting to this in the comment you just made, is there a third measure about the bias at point of care and the care provider that should be measured as well, or find a way to quantify that or assess that?
Yes, there should, and I think that's a point that needs more I don't have it, but I think it's a point that needs more study, and frankly, it needs a bit more work. We know that physicians and healthcare providers on average are at best no better than the general population in terms of both the implicit and the explicit level of bias they have against minority patients, against women, against people of low income. And so when you ask how, especially when stressed out, especially when managing high patient volumes, that affects their care and the decisions they make, it is likely to have a substantial impact. Everyone deserves equal treatment, fair consideration from their physicians. And unless we can create a group of healthcare providers that is able to deliver that, we are seriously deficient.
All right, please join me in welcoming Dr. Baugh for an extraordinary, truly a tour de force, and I can't think of a better way to open this meeting. Thank you, Dr. Baugh. It reminds me, one of my favorite quotes is that statistics are human beings with the tears wiped away, and you allowed us to see those tears today, even in the face of research and statistics. So I know we ran over. The beauty of this is that I have a lot of time, and I'm happy to cut into my time, so that's glorious.